Good evening again. Thank you for coming out in this inclement weather to the Borough Hall's Town Hall on Ebola and Enterovirus. Your presence here this evening shows that we are in need of the facts about these viruses. Borough President Eric Adams believes that Brooklynites coming together to become aware and educated on these matters is what makes Brooklyn strong. This is why he believes it is so important and has taken action to bring us together with the experts here tonight. He will be joining us shortly, but he asked me to begin the program so that we could have our discussions going. If after the presentation from our distinguished panel, and you will be introduced to them shortly, if you have questions at the end of the discussions, please write your name and the question on the index card that were given to you when you signed in. If you don't have an index card, you can raise your hand after the discussion and we will get index cards to you. Staff will go through those questions to streamline the process and eliminate the duplicates. In advance, I want to thank you for sharing your thoughts and your questions, which will help us this evening as we move forward in combating the spread of the Ebola and protecting our children and community. I want to just say a quick thank you to the New York City Commission on Human Rights. Director for the Brooklyn office, Derek Slaughter, is here, and they have a table outside. So because we think it is so important for you to understand the city, state, and federal laws, we brought the city's Commission on Human Rights here today, and they have a table outside. So after the meeting, please, if there are questions, there's a table outside and there's materials that will help us move this along. I want to take a quick moment to thank our staff who helped us to put this meeting together in less than a week. Especially Candace Julian and Michael Mutel, but thanks to all of the Borough Hall staff for all that you do. A quick couple of shout outs. District Manager for Community Board 4, Nadine Whitted. Reverend Daltrey from the House of the Lord Church on Atlantic Avenue, thank you. Derek Slaughter, I just mentioned again from the New York City Commission on Human Rights. Lieutenant Marvin Louis from the Brooklyn North Community Affairs Unit. There's a representative here from Congresswoman Yvette Clarke's office. Pat, what's your last name? Pat's not in the room. And Natasha Burke, representing the Director's Office for Kings County Hospital Center. Enough from me. I know you're here to hear from the experts, so I will now turn the meeting over to our moderator, Professor Mordecai Goldfeder, who is the Director of the Health and Medical Unit of the New York City Office of Emergency Management. Thank you.
Thank you so much. I just want to thank everyone right from the outset, everyone coming out on such an important topic. I know she said I'm from the Office of Emergency Management, but I want you to be rest assured that right now we're not in a state of emergency. My job, though, as the Director of Health and Medical, is to work with all the other city agencies to prepare so that in case we do have an incident, we're ready to go. And I will tell you that every city agency in New York City is working night and day to make sure that we're prepared for anything. So I'm not going to waste your time. Let's hear from the wonderful speakers that we have tonight. So I would first like to introduce from the New York City Department of Health and Mental Hygiene, Dr. Maybank.
First of all, thank you. I want to thank all of the just the experts that have come together to really deal with this issue. I had a meeting this afternoon with HHC, and he gave me a history around the time when HIV and AIDS started. There was a child who was infected through an infusion of blood, a blood transfusion, and his name was Ryan. And because of that, he was thrown out of schools, and no school will allow him in. People thought that if you breathed on individuals, or if you talked to someone, or you sat in a seat next to them, that you could be infected. And in fact, there were laws on the books that stated whoever had HIV was not allowed to fly in an airplane, because people didn't realize. And so we have an obligation and responsibility, those of us in government, to really take away hysteria and fact from fiction, and make sure that the everyday public is aware of some of the information that's being released. There's so much information that's coming from the mass media throughout the country and globally. We don't want Brooklyn or New York to be a place where we are uninformed. We believe in the Sims model. The educated consumer is our best customer. And so I want to thank all the men and women who are here today by giving us information, answering your questions, so that you can be prepared, particularly those of you who have children in school. You're hearing about this virus that's impacting children outside of New York State. And I think it's important that you know about Ebola and any other questions that you may have. And so, again, I'm going to sit down and have a seat for me here, but I don't know if I want that. I want to be in the panel so I can ask some questions too. But again, I want to thank you. Let's give our panelists a hand and thank them for coming out and enjoying the day with us. Thank you very much.
Okay. So good evening, everyone. I'm Dr. Aletha Maybank, and I'm Associate Commissioner in the New York City Department of Health. And I specifically am the new director for the Center for Health Equity. So we're very happy to be here tonight. We're very thankful that the Borough President convened this forum, because we think, as he said, it's very important that we get the information out. If there's anything that will perpetuate a problem, it will be fear, it will be misinformation, as well as miscommunication. So I'm going to go through these quickly because I only have 5 minutes, but I can guarantee you this slide set is more than 5 minutes long. But I want to just make sure that everybody gets kind of the key points and the key messages. And so as most people have heard, in the news, this is right now, Ebola is really affecting West African countries, and especially Sierra Leone, Liberia, and Guinea. Those 3 areas, and these are the affected areas in that particular region. And it really is the worst outbreak of Ebola that we've probably ever seen. There have been lots of cases, over 75,000 suspected cases, and even more. This was actually of October 7th, so we definitely know that there are more cases, and over 3,000 deaths, and even more than that as well reported at this time. In the United States, we know that there are 2 Ebola-acquired cases, so the 2 nurses that we have all heard of in the news are the 2 acquired cases. We had 1 Ebola case that was diagnosed here, Mr. Duncan, and we have had cases that are transferred to the United States from cases that were acquired from our African nations, and folks were brought here to the United States to be treated, which I think is a very important point as we move forward when we think about treatment and we think about the infectiousness of the disease and who tends to be susceptible to getting the infection. But I'm going to come back to that. It's known as a zoonotic virus, just for those who are known. It was first discovered in 1976 near the Ebola River, which is now the Democratic Republic of the Congo. Symptoms, and many have heard this, is that there's an incubation period. So from the time you actually get the virus, from the time that you are exposed to the virus, from the time when the symptoms can appear, can be anywhere from 2 to 21 days. What we are seeing is mostly that the symptoms tend to appear between the 8th to 10th day. And they can start off with symptoms such as flu-like symptoms, fever, runny nose, cough, but then they can become very severe with headache. And as somebody gets very, very sick, as Mr. Duncan probably at the end of stage of his life, they have a lot of fluid loss, anywhere from 10 to 15 liters of fluid loss per day, from vomiting, from having secretions that are coming all out of the body from many different places. The transmission, and this is very important, I'm sure you've heard, and hopefully you've heard, it is not spread by air. It is not spread through air. It is actually pretty difficult to get Ebola. The only way that you can get Ebola is if you have direct contact with somebody who has Ebola and you have had contact with their fluids, and the fluids that I just mentioned before. Again, you have to have direct contact with somebody who has Ebola. And again, that becomes very important too, because people talk about, well, what about when we're on the subway? And what about if we're here and there? For the most part, if somebody is that sick with Ebola, they're not going to be walking on the street. They're just going to be that sick. They aren't going to be walking on the street. And the other important thing is that with Ebola, infectiousness actually increases as the person becomes sicker. So again, if you take a case like Mr. Duncan, if you remember when he first came, he was actually living with family, correct? None of those folks have acquired Ebola, and they were in very close contact with him. But it really wasn't until the nurses that were in that hospital that were treating him when he was very sick, so this time when he was having a lot of the fluids that were released from the body, that he actually came in contact, and actually the nurses were at greater risk of potentially getting Ebola. So then it comes to, well, what about the nurses and their risk for getting Ebola? So we've heard a lot about, I'm sure, PPE or personal protective equipment. We've heard whether it was used properly or whether it was taken off properly or put on properly. If we look at the 4 other cases that we know that have definitely been treated in the United States, in Nebraska as well as at Emory, none of those nurses acquired Ebola from treating the patient. And so that's why it becomes very important, and I'm sure all of our hospital partners are going to speak here about people knowing and healthcare workers knowing what are the protocols, what are they in place, what are the policies, and making sure that they are trained around these protocols and policies. It becomes very, very important in the treatment of Ebola. There is no cure for Ebola at this time. Yes, we've heard of some definite treatments and testing for treatments, but we have no cure and no vaccine, and we have no cure at this time. There are experimental drugs. The fatality rate is actually, here it says greater than 50%, but we're actually noticing it's as high as 70%. But we don't know what that would translate to in the United States because we have a different healthcare system than there is in West Africa. So our fatality rate probably will not be as high if it were to happen at any close rate to the way it's happening in West Africa. Why is it so large in West Africa? Well, there's an overwhelmed public health and healthcare system. It was easy to cross borders. Many people could travel. Many people were not seeking hospital care. There was a lot of stigma, and people were afraid to seek care and are still afraid to seek care. There's a certain amount of distrust in government of outsiders and lack of knowledge of disease and transmission. So I say to people, with all of these things potentially could happen right here in the United States. Again, if we don't get the information that's out there, if we don't have communications, we don't have conversation and dialogue around all of the factors related to this, all of this can happen, and all of this, to some degree, is actually happening right now. Again, we know about the first case that was in Texas. And so what is New York City doing to prepare? Well, we're providing guidance to providers and facilities, protocols for looking at surveillance and just seeing what is happening across the city. We have laboratory testing, and we are able to test in New York City, fortunately. Hospitals are becoming prepared. All of us are working, I'm sure everybody at this table is working around the clock to make sure that the hospitals especially are prepared. There's a lot of interagency coordination that was mentioned, and we're doing certain levels of community engagement as well. I'm going to speak specifically to community engagement because we're doing a lot of this at the health department in addition to all the conversations with the hospitals and the other agencies. But it was very important for us that we reached out to the West African community because they were at greatest risk and still are at greatest risk because people travel back and forth to potentially being exposed to Ebola. And so we convened many groups, we met with many leaders, we received information from people probably in this audience on who should we reach out to, who should we talk to, who should we get information, what are the best communication pathways, what are the concerns, and how can you best help us guide our outreach as well as guide the materials that we create. And so from that, we've been doing either partnering with town halls or doing town halls in every single borough. We had one where the commissioner actually came to last Friday in Staten Island. We also had one in the Bronx coming up, and we have one in Harlem. But we're also reaching out and working with the taxi cabs and with TLC. We have staff that are going to be on the streets next week giving out palm cards, which are outside to beauty salons and barbershops. We are working with faith-based organizations. We are working with lots and lots of people within the West African community at this time. And now we're really moving into phase 2 because it's not only the West African community that needs the information, correct? It's all of us who need the information. And so we're going to be launching a public service campaign within the next week or two. And we're just going to make sure we really get our voices, and we're present on local as well as ethnic and national media as well. And we also have a speakers bureau. So if somebody has an event, all of our doctors in the hospital, majority of our doctors in the health department are trained on giving Ebola talks and Ebola one-on-one, and we can link them up with events that are happening, again, to make sure that everyone is getting the information and the accurate information that they need to know. A key consideration that I bring up, this is very important to the commissioner as well, and our concern is the rising level of stigma and discrimination that we are hearing from our partners. And I'm glad to see the Human Rights Commission here. We were talking with the Human Rights Commission the other day to figure out how we can better partner so that when folks are discriminated against, that they have a resource to go to. But we're hearing stories of kids not going to school because they're getting bullied. Aid workers who are being told by their agencies that they cannot go into certain homes. We have taxi cab drivers who say that their businesses have gone down because people will not come into their cabs, which then has impact on not only their personal space and their personal economic situation, but many people also send money home. And we don't want that to happen. And what we really don't want to happen is for somebody who does have symptoms and who's afraid to go and seek care, and they're going to stay in their home. And we want everybody to know that no hospital should be asking you about your immigration status, nor your ability to pay. You should not be denied care based on your ability to pay. And so we really, in all of this, want everyone to remember that this is a human tragedy. Ebola does not have biases, and we really must stick to the science that we know, the facts that we know, and just what it is that we know about Ebola, and really do our best to quell all the fears and the myths that are out there. As far as the resources that we have lots. We actually set up a specific website with lots of information about Ebola. There's one for healthcare providers. There's a link for colleges and universities, for daycares. We have an Am I at Risk palm card. There are lots of questions that we are getting asked over and over again, so we even have that list on here. But I encourage everyone to go to the website because you will find lots of information. And any of that, if you want any of that information, you can also call 311, and they will actually send you hard copies. So they'll send, and we also actually did one just lately. The other concern that is coming out of our communities is the issue about mental health. And a lot of our families have gone through a lot of trauma in the West African community. Many people have had over 15 family members die in a matter of months. 15. So you can imagine, not only are they dealing with that suffering and loss, but then having to deal with the stigma and the discrimination that potentially happens here. And then their own personal fears about what does Ebola mean. So we encourage you, if you live in New York City, if you have relatives in West Africa, to educate them on how you protect yourselves. And we're about to come out with a sheet that will also help and be useful for folks back home. If you have a visitor from an affected country in West Africa who became sick in the last 21 days of arriving and has symptoms consistent with Ebola, bring them into the emergency room or call ahead of time as well, because we understand not everybody's going to be home or have access to a phone to call ahead of time. But if that's the case, then go to the emergency room as well. Lastly, so we can move through, is remember that this outbreak continues to evolve honestly on a minute-to-minute basis. We are meeting every single day, multiple times a day, making sure we're coordinated with the federal government and with the state government and with the hospitals and with our other community health centers and with our community partners, and there's constant evolution. There are no cases, very important in New York City, there are no cases. I hear some things flying around, but there really are no cases in New York City. And all of us I know at this table are taking really extreme measures to make sure that New York City is protected and all of you are protected as well. So again, if you have any questions, if you want more information, you can go to the website at nyc.gov/health, or you can go to the cdc.gov as well. And here's just one of the palm cards that we have, and these are outside of the table. Am I at risk? And we're distributing these. We've distributed thousands of these already across the city to make sure that people have information. Thank you.
Thank you. Before we continue, I'd just like to acknowledge Lisa Lashley, the Chief of Staff for State Senator John Sampson, is in the room. Thank you. So to continue this program, thank you, Dr. Maybank. That was wonderful. Everyone will have an opportunity later to submit questions. So this way we'll have a little organized fashion so we get everyone's questions answered. I know that there are people who come here with concerns. But at this time, I'd like to introduce the Chief Medical Officer from Kings County Hospital, Dr. Gassam.
Thank you. Thank you. Good evening, ladies and gentlemen, Mr. President, dear panelists. So I'm going to talk very briefly to inform you about our preparedness as a hospital and as a system to face this problem of Ebola. We are at Kings County Hospital, part of the New York City Health Hospital Corporation, and we take care of the largest number of New Yorkers here in the city. So we have started really preparing for the Ebola very early on, way before the case of Mr. Duncan. And we want to ensure really that we provide the care for any potential patient who can present to us, and at the same time ensure the safety of our employees and their family. So what we have done is educating our staff first about the screening, about isolating the patient in a safe way, and about taking the subsequent steps in order to take care of the patients. And as you have heard, we haven't had yet a single patient. Hopefully we won't. In case that happens, we are ready for it. So the first point is that not all hospitals are going to take care of a known Ebola patient. In other words, if there is a patient who is high risk, who is symptomatic, and the patient calls EMS, there is a travel history to these countries, this patient is not going to go haphazardly to any hospital. They are going to go to designated hospital. In our system, the designated hospital is Bellevue Hospital, where they are prepared and they do every day more preparedness to take care of a known Ebola patient. The second thing that we did in the hospital is really to train the people on the front line how to protect themselves and take the right history in a safe way from the patients, and then take the necessary step to ensure the care of the patient in a safe way. So we have trained really the staff about how to do what we call the donning and offing, and that's how to put the personal protective equipment, PPE. So you hear it in all the news. So this way we ensure that the patient is taken care of and the employees are safe. And you might have seen a lot of changes and noise in the news, but the CDC finally came out with like standardized criteria yesterday or the day before yesterday in the evening. Yesterday morning it was all standardized, and we have been all updating our recommendation and policies and protocol accordingly, and we have been training the staff in a competency-based fashion about how to do this and how to do it safely. The other thing that I want to say about the preparedness was we call it drills. So we've been doing drills at HAC for about now 6-7 weeks, and these drills have different levels. We have had what we call like quote-unquote secret shoppers, and these are run by our simulation center, where like patient will come into our system and present with the same symptoms of Ebola, and we see how we respond and what we do during these simulation drills. So the people who take care of those secret shoppers don't know that these are not real patients. And we track this, and we see, what we learn and what we are doing right. And we have done very well during those drills in all our facilities. The other things is that we do daily drills, tabletop drills, in all our ports of entry. So all our ports of entry, whether it's in ambulatory care, in the emergency department, in the behavioral health emergency department, or in labor and delivery, we have been doing drills for every shift for all the employees that are involved or would be involved in such a presentation. Lastly, what I want to say is it's very important to learn from what has happened in Texas. And what has happened in Texas really sort of shaked us all, and we keep thinking, what went wrong. But obviously there was a breach into all those protocols that were recommended by the CDC. That's one thing. The other thing that we learned from Texas is that the family member, this is what Dr. Maybank said, family members of the late Mr. Duncan were in close contact with him, but he was not symptomatic. None of them got sick, and they were released from their quarantine the day before yesterday. So really the fear that is in the media, it's a very important message is we don't want to have this fear. So you're not likely to get it in a casual way from somebody, even if this person is infected with the virus during their incubation period. The infectiousness of the virus is really during the late stages. The healthcare worker who got it, whether it's in Africa, in the United States, or in Europe we have a nurse in Madrid. This is during the late stages when the patients are very sick. So we should really learn from this lesson. The second part, or second message that I really want to say is what we have learned from Nigeria. Nigeria really was able to control the disease, and this is an African country which is very close to, or quite close to the other three countries, not by sharing borders, but by sharing a lot of travel in between those countries. And what they have done is really many community activities and education. They haven't controlled the disease by buying what we call the Tyvek suits or wearing masks in the subways or doing things. It's really by educating and controlling the fear. And now this disease is under control in Nigeria. So your role really here is very important really to make sure that people are assured that if we do things thoughtfully in a non-panicky way, we should be okay. Lastly, what I want to say is that, at HAC, we take care of patients irrespective of their ability to pay or irrespective of their immigration status and irrespective of anything else that would really make patients not come to the hospital. So we want the patients or the individual who have traveled to any of those countries, if they have symptoms, to come to us and come to us early. We'll take care of them. We'll take care of them, and it will be very important for them and for their community to come early. So we don't want to stigmatize those patients, as Dr. Maybank was saying, and we don't want to fear to take care of them. We can do it safely, we can do it safely for their family, and we can do it safely for our employees. This is all that I have to say for now in brief. I'm going to pass on to Dr. Lagom, who will give more specific about our emergency preparedness. Dr. Lagom.
So before we hear from Dr. Lagom, I want to tell you that not only are we working here in New York City and throughout New York State, but they're also working tremendously hard on the federal government. And I'd like to introduce Congresswoman Yvette Clarke to tell us a little about what's happening on the federal level.
A pleasant good evening, everyone.
Good evening.
Good evening.
Let me start by thanking our Brooklyn Borough President Eric Adams for his leadership, convening us in this town hall, which is very, very important to all residents of Brooklyn. I want to also thank the Department of Health and Mental Hygiene, the Office of Emergency Management, the Centers for Disease Control, the Doctors Council of Service Employees International Union, and the Brooklyn Hospital for, again, convening us here this evening to answer our questions about the Ebola virus and the enterovirus. And I thank everyone for coming this evening, because it's critical that we hear from those who are on the front lines about just exactly what the landscape truly looks like, and that we as citizens prepare ourselves and adhere to the best hygiene that we possibly can adhere to. The bottom line to this is that you know, we're in a global society, but to the extent that we can do what we can in terms of preventive measures, we're doing the best that we can for our communities. Earlier this week, the Center for Disease Control determined that the 2 nurses in Texas contracted Ebola as a result of the improper use of personal protective equipment. And as you've heard from the doctor who just presented, that should indicate to us a certain level of relief, because indeed it is not until individuals are symptomatic that they present the highest risk to the population. Part of what is important about what we're doing here this evening is that we ratchet down any trepidation that folks may have. Some folks are, you know, going to the extremes, and we want to encourage us to, first of all, look out for one another, but also how to maintain our own health, because at the end of the day, this is a health issue, it's a public health issue, but there are things that we can do as communities to ensure that best practices keep us healthy. Just this afternoon, I participated in the New York State Congressional Delegation Conference call, and I also serve on the Homeland Security Committee, where emergency preparedness is really at the heart of what we're concerned about, and that we are looking at preparedness plans across the entire state. And I am pleased to report that the federal, state, and local governments have effectively coordinated their resources to train and equip medical personnel, hospitals, clinics, first responders on the appropriate protocols to combat this deadly disease. And what I learned, and you probably were informed as well, is that we really had a great infrastructure in place to begin with. So it's really standing up a more robust response, doing more public awareness so that we can ease the level of concern out there, but also be heightened enough to understand how to protect ourselves and how to be able to address the concerns that we do have in terms of where you can go for information, websites, and the like. In addition, when appropriate, there have been, you may have heard, additional screenings of travelers that will be coming into JFK International Airport in New York City and Newark Liberty International Airport and other airports around the nation in an attempt to limit potential exposure by finding individuals who may have the disease upon arrival in the United States. And rest assured that we're really prepared in that regard. I want to caution us, however, we all don't need to become armchair doctors, trying to diagnose our neighbors. And to the extent that we can also just be cognizant of the global nature of our communities and not try to stigmatize people around us, the better off we are as Brooklynites. I think that that's really the important thing, and I think we can lead the way as a global city in managing this as effectively as possible. We have many neighbors from West Africa, not only living in our communities, but worshiping in our houses of worship. And so it's very, very important that we heighten our sensitivity and not allow others either to use this as an opportunity to bash people from other parts of the world. That's not what we're about. We're about trying to arrest this disease right here, should it become an issue. But certainly, as you know, President Obama has amassed a lot of resource and international support to really get over to West Africa and do what we can to arrest it there. So I just want to, again, thank you. I came to learn as much as I possibly can as well. I thank you for the opportunity to address the town hall today. But like you, I live in Brooklyn and interact with all of my constituents, and I want to be as informed as much as possible. So thank you all once again for lending your expertise, standing up your operations, and keeping all Brooklynites healthy. Thank you.
So we'll continue with our program to talk about what they do in the emergency room at Kings County. Dr. Eric Lagoon.
Good evening. Thank you. So what I'd like to do is take you through a little bit of what actually happens when patients come into the emergency room and give you a sense of what we do, what our preparedness has been. I'm going to talk to you a little bit more about Kings County, but one of the things I think you should feel assured is that all across HHC, we take this very seriously. We've had at minimum daily conference calls. We've had multiple workshops, multiple meetings, and I think I could probably even take that across the city. You know, every emergency department understands the seriousness of this, understands the practical nature of what we need to do, and the reality is, and even if we don't, the state is there to make sure that we do, and they have visited us quite a few times. They have visited everyone quite a few times, and so I think from what I've seen and the drills that Dr. Jamalny talked about, we do multiple internal drills, but we've had external drills, and I am very happy to say we've done just absolutely wonderful in them. So I think you should feel very assured that the healthcare providers and the emergency departments across New York City are really on top of this and doing a great job. So let me tell you a little bit about kind of what we do. So part of it is we have some kind of basic philosophical approaches to this. And the first one is that we want to minimize the number of people that would potentially come in contact with a patient who potentially could have Ebola. We do that for several reasons. One is we obviously worry about infection, and we worry about the public health issues associated with that. And so we are training people, so we're training everyone, but that training may take just education, so people understand what the risk is, people understand what to do. And for those who may come in contact, there's an extra level of training which really revolves around putting on and taking off personal protective equipment. So anyone who might come in contact will be an expert at that. So number one is we minimize the number of people in contact. The second is we minimize what we're doing in the emergency department. For the vast majority of the patients that we will see in any emergency department, they will not be critically ill with the disease. And that's very important to understand, is that when people are very ill, for the most part, they are not going to be able to walk into an emergency department. The people that may walk into the emergency department are going to be early in the disease, and as was spoken to before, those are the people that are also much, much less infectious. And just from a practical nature, if you think about what happened in Texas, this was someone who was seen, in the community, lived with people, went into an emergency department, unfortunately sat around for a while, and no one that came in contact with them early on was infected. And so those are the types of patients we might realistically be seeing. Anyone that may be much sicker, those are patients that FDNY has a very, very clear protocol, and they know where to go with those patients. There are centers set up for those patients. That being said, we are ready for them if they do come in, but that is not what we are expecting. If a patient walks in, the first thing we do, and I think everyone does, is there is extensive signage in multiple languages that has pictures of the countries that are infected, that has airplanes, and basically lets people know if they are worried at all, they need to let us know immediately about that. We have trained our frontline staff, our clerical staff, and our greeters. Our expectations for them, though, are that any person that comes to them and has any concern whatsoever, we are not expecting them to do any sort of clinical work. We don't want them asking multiple questions. We don't want them to try to screen them. All they're expected to do is take the patient to a room that's about 5 feet away, give them a mask, and close the door. Because we don't expect our frontline workers to be the ones to do the screening. This is a medical professional's job to do that. So we immediately isolate those people. I can tell you when we had our drills, it was almost immediate. We did a great job. So once they're isolated in a room, we have actually a phone in that room. And so if we need to, we can go ahead and talk to them, ask them questions. Most of our patients, however, will come up to a screening nurse as soon as they walk in, and we have a very clear set of questions that will either screen them in or screen them out. Did they travel to one of these countries in the last 21 days? Do they have any symptoms? If they do have a positive screen, we'll once again isolate them immediately and prepare our isolation room. We have a room standing by for those patients. We actually have 2 rooms standing by for those patients to go in. The providers get ready, the gowns, the gloves, everything. When we have pre-made kits, so we know exactly what they're wearing. They've been trained, and we have a group of people on every single tour that has been trained to put these on, to take them off. We have spotters to watch them put them on, spotters to watch them take them off. We get them in the rooms, we do examinations, we get the full history, and before we do any other testing, before we do anything that might involve blood and IV, et cetera, we get the Department of Health involved. The only time we would not do that is if a patient is critically ill and we need to do something for that patient. We will do blood if we need to. We may put an IV in, but will not be done until everyone is gowned and gloved appropriately. And once again, it's a minimum number of people that come in contact with that patient because we want to minimize the risk to our providers. We want to minimize the public health risk. On the other hand, we do have a expectation, a need, and a duty to take care of our patients. So we will always do that. Once we get the history, we will speak with the Department of Health, and based on the risk factors, for the most part, any patient that is a very high-risk patient will be taken care of in one of the institutions that cares for the high-risk patients, such as in our setting, it's Bellevue. So we have a very, very clear stepwise approach, and actually ours is written out. What do you do the first 5 minutes? What do you do the next 10 minutes? So everyone knows exactly what to do. We've done extensive training as far as donning and doffing, and we're continuing it because, to be honest, the gloving, et cetera, has changed a little bit from the CDC, although it has not been a marked change, but it has changed a little bit. And as it changes, we're evolving and we're changing our training. But for the most part, it is a relatively standard. And some of the good news is that because we do so many drills for things like disasters, most of this we have done training in this in the past. So we feel comfortable, we're taking it seriously, we are ready, and I think I can speak for all of HHC, and I believe I can actually speak for the other emergency departments in town. Thank you.
So before I call the next speaker up, I just want to thank Mr. Leroy Charles. He's the Vice President of External Affairs at Brooklyn Hospital for helping to put together this event and working with the Borough President's office to pull this off. So thank you. To continue this talk, or to talk more about the enterovirus, a bit different, I'd like to call Dr. Michael Hochberg, Chief of Emergency Medicine at Brooklyn Hospital.
Well, I want to thank the Borough President definitely for convening this. I actually won't be talking that much about the enterovirus. I'm going to leave that to my colleague, who's the chairman of pediatrics. But I did want to talk a little bit about Ebola and echo some of the comments that have already been made here on the dais already. Even though Brooklyn Hospital Center is not an HHC hospital, we have been undertaking a series of drills and preparedness for months now. We have actually been screening every patient that has come in through our emergency department since August. And during that time, we've called the DOH on 3 patients, and all 3 of them are low risk, and all 3 of them were discharged. So we've been aggressively following this since the start. Certainly over the last couple of weeks, our protocols have become more refined, and we do everything that Dr. Legault mentioned in terms of the screening, the gowning, the drills that undertake. Definitely as somebody that watches the news and reads the media, it's understandable to be frightened about this based upon what you read, but it's not necessarily reality. If you read, you think tomorrow you're going to wake up and it's going to be The Walking Dead all of a sudden. And that's not reality, because when you think about it, in West Africa there have been thousands of cases of this, but there's actually another virus which affects millions of individuals yearly, and that's just influenza. And that's something we don't always think about. But influenza can be a deadly disease as well, and something that we actually can treat, and we have vaccinations for. So we think about Ebola because it's in our face and we read about it, but something that affects much more and many more people is something that necessarily is not given as much media attention, but certainly should. So always think about that. The media drives things in a certain way because it drives sales, it drives people to their websites, to their outlets, but once again, it's not necessarily reality. I joined the Brooklyn Hospital about 11 months ago. I'm a born and bred New Yorker, and born and bred person in the Bronx, don't tell anybody. But I joined it, I trained at Jacobi, and I joined Brooklyn Hospital Center because I have a deep belief in inner city emergency medicine. To really take away the stigma that exists with inner city emergency medicine. Because oftentimes when you think about inner city emergency medicine, you think of crowding, you think of inefficient care, and that's not necessarily the way that it should be. And I know all the hospitals in Brooklyn are striving to improve care, and it's certainly my mandate that I have at the Brooklyn Hospital Center. And so I want everybody to know when they come to our emergency department, we're going to treat you promptly, we're going to treat you fairly, we're going to make sure you're safe, your family is safe, because even as we screen you as the patient for symptomatology that may be associated with Ebola, if you arrive with a visitor, you arrive with a family member, we're going to screen them as well, because we want to make sure that they're safe just as much as you are potentially as the patient. So once again, I want to echo what our esteemed colleagues on the panel have said. Ebola is scary. Definitely when you read about things, it's not necessarily reality. There are even deadlier things out there and things that we can treat, such as influenza, so definitely get your influenza shot. And with that, I thank you.
I would like to recognize Julie Dent, the chair of Community Board 4. So without further ado, Dr. Kenneth Bromberg, the chair of pediatrics at the Brooklyn Hospital.
Thank you very much for having me here. Conveniently, when this is over, I could stop off at Trader Joe and pick up the olive oil. It says the greater viral threat. Mother Nature is the best bioterrorist. Mother Nature is the best bioterrorist. So influenza changes every year, and that's, we could be real scary about that, just like people are scary about Ebola, and I think the point was made, vaccination. New York City now requires kids in daycare to be immunized against influenza. It's likely that we can do a lot better of controlling influenza by immunizing all of you out there, including children. Children are frequently the source of it. So that's the greater viral threat if you put it in perspective. I'll talk a little about the enterovirus. You've read about this in the paper because we have a new thing to drive the headlines. There's a lot less of it. Enterovirus is the same virus, from the same virus class as poliovirus. There's a lot of parallels between panic that's going on now with Ebola and polio. I remember people with polio. The last big polio outbreak was 1954. and we were able to create a vaccine and deal with it through public health. We have to remember that we're lucky. We still have a public health system, and that's going to help us at this point in time. The enterovirus was causing a lot of respiratory illness. We know we had it in Brooklyn Hospital because in conjunction with the New York State Department of Health, we did surveillance. It's clinically starting to fade away. We're seeing fewer and fewer kids. It caused a respiratory illness. There were some deaths. You read about it in the paper. But there are always deaths. There are deaths from kids with asthma. This was an asthma kind of thing that happened no matter what you do, although influenza vaccine helps prevent asthma exacerbations. There were also another scary thing, because this is in the same family as the polio virus. There were a few kids who developed paralytic illness after this out in Colorado. We haven't seen any in the Brooklyn Hospital. There were, I believe, 2 or 3 cases up in the Bronx and Montefiore. I know there were 1 or 2 cases in Syracuse, so this is unlikely to be a mass problem. The major thing was respiratory illness, and just looking at the amount of this in the emergency room, it looks like it's fading away. There has always been enteroviruses. They come in the summer and the fall, and once again, they vary thanks to Mother Nature, and sometimes they do weird things, and sometimes they don't. So I can give you the good news. I'll tell you that the enterovirus will go away, and we'll have one less thing to be worried about. Thank you.
So we heard from our local hospitals here, but we want to make sure that all hospitals are prepared. So to talk a little bit about hospital preparedness in general, Dr. Frank Proschio from the president of the Doctors Council.
Thank you very much. A lot of what has been said was what I was going to talk about, but I'll just, reiterate some things. Ebola has been around since '76, and there have been multiple outbreaks. It's been controlled before, and it's going to be controlled again. There's been no natural host for this virus. We believe it's from bats. And it may have, propagated in, bushmeat out in Africa. As long as you don't purchase, the bushmeat here, I think you're relatively safe. It is not transmissible by air, water, or food here in the United States, so be assured. In terms of the risk, the highest risk goes to the healthcare workers and those who treat patients with Ebola. So I could at least put all of you at ease with that. The signs and symptoms, as has been said, occurs between 2 and 21 days from once you have the contact with an Ebola virus. And the symptoms are relatively like the flu. It's extreme fever, usually above 101.5, malaise, nausea, diarrhea, bleeding, abdominal cramps. It mimics the flu. It really does. And a lot of people may think they have the flu. One way that you could help the healthcare system is, as has been said, get the flu shot. At least those cases that show up in the emergency room will be eliminated, so that the healthcare workers could focus on the real risky patients. And the illness, as has been said, it's only spread while the patient is symptomatic, and the sicker the person gets, the more infectious they become. So usually a person who walks into an ED is relatively infectious. You're not going to get the illness just passing them in the hall. That won't happen. The treatment, as has been said, there's no vaccine. It's usually symptomatic. We have to rehydrate the person. They lose a lot of fluids. We have to maintain blood pressure, the oxygenation. We have, if the person has a secondary pneumonia, we treat the pneumonia. It's symptomatic. So as long as the person survives the illness, they're essentially immune to that Ebola for the next 10 years, okay? They have antibodies to it. There is some talk out there to make a convalescent serum, they call it, in terms of, they're trying to do research on it now to see if it's a possibility that a person that has went through the Ebola, now that his blood or her blood could be utilized to try to save others. That's in the research phase right now. I want to say, in terms of the preparedness in the hospital system, there is extreme collaboration between the CDC, the departments of health, and the hospital systems. I know specifically, the HHC system. There's a lot of, collaboration going on, and I suppose it's happening all throughout the system. No one wants a reoccurrence of what occurred in Texas. At that time, everyone felt that they were doing what was appropriate. Unfortunately, it was probably not the case, and everybody stepped up the game. We've increased, the gowns that we're wearing, the coverage, no skin exposure now, whereas in the past there may have been, some neck exposure. There's a buddy system in place now, as has been mentioned, that oversees anyone putting on the gear and taking it off. If there's any problem, they disinfect the person. And usually it's an alcohol-based product that's used to disinfect the person, or something like bleach. As the doctor stated, there's intensive training going on, intensive drills going on, testing of employees. It's almost good to see people make mistakes during the drills, because then they'll know never to forget that again. There's a systematic way on putting on the clothing and taking it off. It usually takes about 10 to 15 minutes minimum to put on the gowns and everything, and the face masks, and the shields, and the gloves, 2 sets of gloves. And every time you do something, you wash your hands with a disinfectant. Regardless if you're putting on the stuff or taking it off, you're even washing your gloves. They're trying to minimize any contamination of the Ebola. So if anything gets on the person's shoes, the shoes are wiped, with an alcohol wipe. Everything. We're trying to minimize exposure. In terms of the PPE, that was mentioned, the personal, protective equipment, that's not all that's being done. Staff is also disinfecting the rooms immediately afterwards with a bleach product, something like that. Ebola is very fragile. It doesn't survive well, okay? Once it dries up, it usually dies in maybe a couple of hours, okay? It's a very fragile virus, and things like bleach or an alcohol wipe can kill it. So remember what your mom used to say: wash your hands, wash your hands, wash your hands. And that is the safest thing you can do as a public. Healthcare workers in any facility are being trained one way. When I went through medical school, when I went through residency, the one thing they taught me was, when I go see any patient, imagine the worst infectious illness you could see. Treat that patient like that patient has that illness, okay? So every staff member is being taught, think Ebola, and they are very cautious in how they handle things and how they enter a room, how they exit a room. As a doctors union, we're a national union. We have doctors in Chicago, in Pennsylvania, in Jersey, here in New York. We, regardless, and I know any doctor, regardless if they're in a union or not, we stand ready to care for our patients that may be at a high risk for Ebola. We'll do that regardless. It's the reason why we're in this field. The risk of an outbreak of Ebola here in the United States is extremely low, as per the experts. And I want you to be reassured by that. This is not, the backwoods of Africa. This is the United States. The healthcare system is quite good. Doctors here are quite good. And I wouldn't be worried entering an emergency room as a patient that I may be contaminated by something. I know things will be contained here in the United States. I know that Bellevue is in the highest state of readiness. That's why it was designated to be a treatment center by the Department of Health and by the governor for this region. It's in the highest. They've known infectious disease going back to tuberculosis. It was built for that purpose. Okay, the staff there There's nothing but the best in terms of treating patients. And even when a patient is transferred to Bellevue, let's assume there's 2 or 3 patients that actually have Ebola in Bellevue. They probably will airlift one of those or 2 of those patients to other hospitals around the country. Because what the CDC and the Department of Health is trying to do is to spread out the work, because treating an Ebola patient is intensive. It takes a lot of resources for one hospital to handle multiple patients. It's like those nurses in Texas. They were both shipped to 2 other hospitals. I think one was Emory and the other one, I don't recall it, maybe it was in Nebraska, I'm not sure where. But it was shipped to other hospitals that all they do is, like Bellevue, they know how to treat infectious disease. And as I said, Bellevue is in the highest state of readiness, but we have to make sure that we expand the range of safety if we can. If there is a consideration, maybe we believe we could add something to it to make it even better, there should be a discussion with the CDC and the Department of Health, and I imagine the hospitals are doing that. Okay, just a few weeks ago, we started a dialogue, a labor management dialogue with, the Health and Hospitals Corporation. They're calling in all the unions. And after that dialogue, they started town hall meetings at the behest of labor. They started having an internet, they started putting all the protocols on the intranet so that all staff, has accessibility to it. That is HHC policies. There's an email and a hotline if there's any questions or suggestions that usually is answered immediately. So any other hospital, like Brooklyn Hospital, is probably mimicking that. But I've been working in an HHC facility for nearly 20 years, for 20 years. I've worked in Newark at University Hospital. I've worked in Chicago at Norwegian American Hospital, all safety net hospitals. And there's nothing but the best, because as was said earlier, we don't care about the immigration status. We don't care about the money. We care about treating people. Thank you.
Again, I want to thank everyone on the panel, but most of all, I want to recognize and thank our Borough President Eric Adams for showing very strong support. I'd like to call him up again to make some closing remarks.
Well, I just want to, we want to open it to questions, and as they used to say back in public school, no question is a silly question. So you should really take this opportunity to just inquire and just get sort of the answers to some of the questions you have. I had 2 I was jotting down as they were speaking, but we want to make sure that all questions are asked on topic, and there was just one off-topic question that I want to read, so that I like reading everybody's questions. Someone raised the question that why has Eric Adams and Bill de Blasio been so quiet about saving Lynch, which is causing overcrowding at other hospitals right when we may need it. I think that both Bill and I, Bill being the mayor, has been extremely vociferous around saving Lynch. Was one of the earliest people who were there fighting for Lynch. The advocates, one of the advocates had me as one of the judges of the hospital, what Lynch was going to become. And when I became one of the judges, I had to sign an agreement that I would make no public statements after I was given the information to look at all the RFPs. So I was not allowed to make any more public statements after that. And our attorneys looked at it and stated that you are binded by that agreement that you signed, and I was not going to violate that agreement. And so to the doctors and the panelists, I had a question around. We heard that blood transfusion actually is being used for the nurse who was infected. So I heard that there's no cure. So if one is infected, can you use blood transfusion? Is that a way of fighting this disease, although there's no cure?
So I can answer this, Mr. Adams. The plasma of of patients who survived Ebola has a high antibody against the Ebola virus. And if we take this plasma and give it to an Ebola patient, so it might kill the virus, but they have to be of the same blood type. So that's has been used. But again, you know, to prove the efficacy of this, you need to do it on a large number of patients. So that's the idea that was sort of talked about, and Mr. Duncan did not receive it. This is what the hospital say, because his blood type did not match to be able to use that plasma.
So if I understand you correctly, that if you're going to do the transfusion, you must have the same blood type as the person who built up the antibodies?
Yes, this is what the protocol called in for. And again, you know, this is not a standardized way.
Is there any such vaccination or vaccine that one could take?
As we speak today, there is no vaccine like the other vaccine, like the flu vaccine or other vaccine. There are two vaccines that are being investigated. One was developed here in the United States, and the other is developed in Canada. But they are still under investigation.
And lastly, to one of the doctors that was dealing with preparedness, how did Texas happen? How did the nurse in Texas, what would have caused, was her neck exposed? Like, what would have caused that?
They haven't really released the specific. They released an apology saying that there was a breach. But we know that at the late stages of the disease, the patient become quite infectious, and they have a lot of secretions, whether it is like diarrhea or vomiting, or even blood or secretions from the air tubes from their lungs. And we are just guessing that probably during like taking off their protective equipment, they might have touched their skin, and they didn't realize this. And that's why now the protocol is very strict, that somebody should be observing the person who is putting on and taking off the protective equipment.
Good. I'm sorry, you want to?
To add to that, one of the things that people get confused about, and rightly so, is, you know, why don't you all wear 3 pairs of gloves? Why don't you all tape? Can you hear it? Okay, better. So one of the confusing things I think is what people don't understand is, why don't we all wear 3 pairs of gloves? Why don't we tape everything down? Why don't we all wear Tyvek suits? And it really is a balance. You know, some things may provide slightly better protection, but on the other hand, where people tend to get contaminated, it's not necessarily when they're with the patient, it's when they're taking them off. And the more layers you use, the more tape you use, et cetera, the more likely you are to contaminate yourself when you're taking it off. Also, the more you put on, it's actually very hard to work in some of those suits. You get tired very quickly, they're extremely hot. And so you're really striking a balance between what makes sense to take care of a patient, what keeps you protected both while you're with the patient and when you are taking the protection off.
That's a good point that you just raised, and probably what we need to do, because if you believe someone in your household is infected, I would love to hear about what you should do in that household, and how, because there is a way of putting on and off gloves after you touch something that's infectious that you can be infected with.
I would, in case somebody or a patient is brought into the system and he is proven to be an Ebola, I would let the authority who are expert in doing this do that part. So I don't want the public to do things on their own. Just like we will follow the CDC criteria, the New York Department of Health, and they will give us, you know, guidance about, and guidance to the family, what they should do.
Okay. So we want to open the floor up for questions. I believe we have some, but at first we were joined by our councilwoman. And can you just bring greetings quickly to the audience before we start answering the rest of the questions? Councilwoman Lori Cumbo.
Good evening. I am Councilmember Lori Cumbo, but I am really sitting in the audience as one of you. I'm here to learn and to gather as much information as possible. We've had 3 of these sorts of forums at the New York City Council, and we have been gathering information and learning as much as we can so that we can be as prepared as possible. So for me, there aren't enough panels going on that I feel that I've learned everything. As the information continues to unfold, we continue to learn. So go to this one, go to another one, continue to gather the information and to share it with others, and encourage individuals to attend these types of panels, because no matter what, this is extremely informative, and it's great that we're connection with our healthcare professionals. So thank you very much, Borough President Eric Adams, for initiating this so early on and making sure that New York City and Brooklyn is prepared. Thank you.
So we have a lot of great questions here, but if you have a piece of paper and you want to keep writing questions, we'll keep going. As long as our doctors are willing to keep supporting us. So the first 2 questions are very similar, so we're just going to ask, what are schools doing about newly admitted students who have just arrived from Liberia? And why aren't school nurses taking the temperature of these children for first 21 days? And a similar question are, how are there preparations being made to control an outbreak in daycare and schools?
Okay, so I'll take that on as far as the health department goes. So right now, we as the agency, feel that it is more appropriate for family if a child is coming directly from one of the countries affected by Ebola, so the 3 that were mentioned earlier, that they are doing self-monitoring, or parents are monitoring them at home for 21 days and taking their fever, and that the school nurse is not going to be taking their fever. However, if a child develops a fever within school, then the nurse will need to contact the parent as well as the healthcare provider or 911 pretty immediately. And then we also, if the parent is available, we will ask the parent to come to the school to come take the child home and also follow up with the healthcare provider at this time. But we are really, the recommendation and the protocol and guideline is for there to be self-monitoring by the parent at home, not by the school nurse, and for 21 days from the time that they came back into the country.
Thank you. Next question. Keeping in mind that we are approaching the flu and the West Nile virus and other respiratory illnesses, how can we differentiate between the Ebola and Enterovirus from other known viruses?
I think the important point, like for example, the kid in school, is contact with someone who is ill. So it's the prior probability. The symptoms of flu and all these other things, not West Nile, are very similar, so that's the assessment. I guess if people are not clear, then they can talk to their doctor or be seen. But the key thing in this whole algorithm will be whether they had a contact with somebody from West Africa, in West Africa. So having contact with someone who's asymptomatic, who may have been in West Africa, is not a way that you're going to get Ebola.
This question is directed towards Brooklyn Hospital. How many cases of enterovirus did the Brooklyn Hospital see?
We probably saw, things that are compatible with enterovirus, several hundred. The only things we did surveillance on were of 8 patients who had compatible illnesses, 7 were positive for enterovirus. We've seen no paralytic illness. We've had no one on respirators. We had kids in the ICU. We had children who never wheezed, who suddenly wheezed at the age of 10 or 11, and we presume those were enterovirus. Enterovirus is not a reportable disease at the current time to the health department.
Ebola has existed since 1976 in other countries and in Africa. Has any health institute or organization contacted them to find out what was done and how Ebola was treated?
Me too. It depends what we mean by health institute. Of course, the whole world now is looking at Ebola, not only the United States, Europe is looking at Ebola, Canada, everybody is. So I don't know the specific, but we are trying to learn a lot from what is happening in Africa and from the previous stories of the outbreak. A good place where if somebody wants to really read the details about this is the CDC website. The other one is part of the CDC subtitle. It's something called the MMWR. They publish all the stories, and I try to read them to keep up to date and learning from them. So there is multiple institutes who are in contact with them.
Could I just add something to that?
Sure.
Is there a plug on this thing?
It's working. It's on.
Hello? Hello? Thank you. Look, I just want to add, now that we have the world's a lot smaller than what it used to be. Now that this virus is in Europe, in Spain, it has affected America. Many pharmaceutical companies are both in Europe and the United States. This is a virus that potentially has a good chance of finding a vaccine for, because people have become immune to it after having it. So probably a lot of people are out there looking for something. Pharmaceutical companies are not going to spend the money, the resources, and the time to search for a vaccine or make a vaccine if there's a little outbreak here or there. This is a global problem now, and I think pharmaceutical companies will look seriously, and research institutes, medical centers are going to look more seriously into it now.
So at the ID Week last week in Philadelphia, we heard a lot of reports about therapy. I was surprised about this, but the ability to measure the amount of sodium, of electrolytes in people's blood really was not available where they were having the outbreaks. And it turns out a lot of, which is why the mortality from this is likely to be less in this country, it's a lot of fluid management. We heard about the massive loss of fluids, 20 liters, and people who lose that much fluid go into shock, get all sorts of end organ damage. So it's likely with modern intensive care, these patients will do much better. The problem is when we start doing interventional things like dialysis and having patients who get to this stage, they're also very infectious. So that's why the need for the appropriate protective clothing, which we should make a distinction between that situation and the patient coming into the emergency room who's going to be evaluated for possible risk. Those people, most of them won't really have Ebola, and in fact, the ones who do are very little risk to anybody else in the emergency room, anybody else in the community. It's as they get sicker, as everyone has said, that's when they're at risk, and that's why it's a good idea that we've regionalized this care, sending them to places where people have the experience. All of the hospitals in Brooklyn have the experience of managing someone with massive fluid loss, but it makes more sense to take a place like Bellevue where people can get more and more experience with protecting the healthcare workers and to regionalize that. But I wouldn't be worried going to the emergency room that the person with a fever who's not that sick is going to infect you with Ebola.
And I want to add to that, so we're talking about Bellevue, which is very important, but we are working with hospitals all across the city, and it's important to know that all hospitals really have the capacity that if somebody presents to their ER, they're presenting with symptoms and they're presenting that they have traveled to one of the affected Ebola countries and have been in contact with somebody, they do have the ability to identify that person as well as to isolate that person as well. And so all hospitals have that capacity and capability to do that. And then if the person needs to be transferred somewhere else, then that will happen as well. The other important point to point out, which I forgot, I'll come back to, but there's I think I'll come back to it because it blanked, it left my head real quickly, but I'll come back to that point.
I mean, if a person is non-transferable, sorry, Dr. Mena,
no,
maybe
okay.
I can finish your thought. If
Thank
a person is
Tired.
non-transferable for any reason or it's unsafe to transfer them, we will initiate the care wherever they are, and we will do it safely for the patient and safely for the employee. So we are prepared to initiate the care in case the patient is unsafe to be transferred.
I know what it was. So the other point that I wanted to make out, because it was mentioned about, how many cases are we seeing. So far to date, the New York City Department of Health has received 155 calls for suspected or suspicious for Ebola, and none of them have become positive, just to say that, in 155 calls that we've received to date.
Okay. So the next three questions are very similar. As a home care provider, how can we educate the home health aides about Ebola without frightening them? A church pastor asked a coalition of churches, how can church partnership with the city and the state to correctly educate? And again, how are public school teachers and staff being protected? What can be done to educate parents? So the first thing is that we can all come to these town hall meetings. Very important, and again, I'd like to thank the elected officials who have shown us support and come out to help get these going for people in the community to come out and see. As Dr. Maybach mentioned earlier, you can go to, I think, any of the hospital websites, any of the New York City websites, the OEM website, the Department of Health website, or just the New York City website alone, and it'll point you in a direction. There's big links for Ebola and for information on it. And you just, you hit one of those links, and there's a place where you can fill out a little form to have someone come and speak and educate. You can also fill out a form, and we'll mail you brochures. Department of Health has wonderful literature. I think there's some out in the hallway that you can take with you. And there's plenty of information that we can offer and come and speak about.
And you can call 311, because not everybody has computer access for whatever reason, but 311 as well. And we've done testing to make sure that when people call that they get somebody to speak with and they get the information that they need. And we're also testing to see how fast people are getting information to make sure that our systems are working well on our side. But we also, from the Center for Health Equity, we are, as I mentioned earlier, reaching out to multiple organizations across the city. So we would value, if you are working with an organization, to have contact with you. Again, and we have a speakers bureau list that we can send somebody out to provide information about the basics as well as materials too.
Could I just add one other comment? The Municipal Labor Committee, it's a coalition of unions that are all the public city workers. It's about 350,000 workers, teachers and such, police, fire, and everyone like that. Just yesterday, I was appointed the chair of the Ebola Committee for the whole MLC, and I'll be chairing it with Ann Beauvais, who's the president of the New York State Nurses Association. So we'll be evaluating with the City of New York, with all the agencies, the protocols, the procedures, the equipment, to assess if it's the best thing that could be done for our city workers and for the public.
Okay. Great. Are there individuals who work in the dentistry profession under the same precautionary guidelines as those individuals who work in the health and hospitals? Dentistry.
Do you want me? I mean, we answered this question actually for our dental. We have a very busy dental clinic. We're doing the screening in terms of asking the travel history up front, and in case there is contact with Ebola or a concerning travel history, we go to a higher level of more investigation, and then if there is a risk, then we can defer the dental unless it is an emergency. Then we need to do it like any other care of high-risk patients. So really the screening is important. So for people who work in dental, it's the same thing. It's asking the travel history and asking about contact and then asking about symptoms.
You know, I think
Could I just add one more thing to that?
Sure.
All specialties in the hospital, including dentistry, OBGYN, all the services, when a new patient comes in, they will all be trained, and they are trained, to ask those specific questions to see if a person is low or high risk. And then Ebola is the most important issue there. So whatever problem they may have, it may wait until they finish the assessment on the Ebola. Okay, and they're going to be contacting probably the Department of Health and the CDC for advice on management of those patients, to assess, the likelihood of it.
Right, and I have to echo that. we have strict protocols in place in our hospital, and the CDC is recommending it as well, that really in all points of entry, patients are screened. So even patients that go to our radiology department for a mammogram are asked, have you traveled and do you have symptoms? Because they're going to be in an environment where other patients are. So regardless of whether they're going to the dentist, the emergency department, the OBGYN, radiology for testing, we are screening all patients before we put them into the system.
I just want to say the Borough President invited the Centers for Disease Control and Prevention, I think they're now being called. But yesterday they indicated that because of overwhelming requests for speakers, they couldn't make it here tonight.
Thank you. Are there any other antiviral items besides alcohol and bleach that can kill Ebola? So who wants to answer? How do we kill Ebola?
I mean, if it is like any soap and water can kill it in the environment, bleach can kill it, and alcohol can kill it, 60% alcohol can kill it. If we are talking about an antiviral like what we use for HIV, there are viral agents, but they are in a test. They are not, they haven't been validated or tested that are effective. They are very expensive to use on a large scale, so it is not...
Could I just add another thing there? Captain Srinivasan from the, the Public Health Agency, the U.S. Public Health Service, at a PQC, it's a Partnership for Quality Care at the Javits Center yesterday. There was a big Greater New York and 1199 in-service, essentially. It's where they had all different agencies come in to speak about things. And he had suggested that there is, if you see a product out there that says it kills norovirus, N-O-R-A virus, that will kill the Ebola virus. So if you see any sanitizer and it states that it kills norovirus, that's a virus that's even more difficult to kill than Ebola. So if it kills that, it'll kill the Ebola. So if you're trying to buy a hand sanitizer, see if you see that word there.
And also within the hospital systems, and this is one of the things that occurred in Texas, and what's fact and fiction, it's really hard to say except for those individuals who were down there, but they had soiled garments, if you read the news, piled up to ceilings, no one knew how to dispose of these things. In many of our hospitals and what CDC is recommending, there are strict protocols on how to dispose of garments, the gowns. We specifically train our environmental personnel on how to properly gown, how to properly clean, so that they're safe while cleaning and they're actually doing the correct job to protect everybody else.
I also, want to bring up again the importance of, but also to make sure we're minimizing hysteria around it as well, and that the importance of what we do normally, that we normally say, the importance of washing your hands after you eat, when you use the restroom. All of those things are still what we should be doing on an every single day basis, and to remember that. And as far as the virus, yes, it can live on surfaces for a couple of hours, but for the most part, it needs a very moist, warm environment to survive. And that's why the fluids, becomes very important as far as a space for transmitting the virus to somebody else if they come in contact. But for the most part, again, most people are not going to contact somebody who's that ill and that sick walking on the street. And that's symptomatic, and people become more symptomatic the sicker they are. When they initially have the virus, if they don't have symptoms, they're not contagious at that point. And those are the people, if anybody that you're going to be in contact with, that's the point that it would be, but they're not going to be contagious at that point. So again, I go back to just doing the things that we have been taught to do from the time that we were little. And it's washing our hands and making sure our kids are washing their hands. I'm sorry, I'm tired, guys. I've done a lot of these. So, and washing their hands, so.
Okay. If Ebola is not easy to transmit and the virus can not survive long outside of the host, why has furniture belonging to the relatives of Duncan been burnt? I don't know if anyone can answer that.
You know, I would kind of put it in why do schools shut down when someone's, it's kind of in why do schools shut down when someone's on a plane in Cleveland? You know, I think there is a bit of hysteria that, you know, some of it is safety, but I think there are certain things that people we're seeing do that may not be scientifically sound. I think some of it's to make people feel safer, but I would say burning furniture is probably not an effective way to combat Ebola.
No.
I concur.
Yeah, we all concur.
Okay. A question, I guess, for the hospital folks. Are there hand washing stations set up? And instead of wiping off shoes, I know someone mentioned shoes earlier, why not throw them away?
The protective gear has covers that are very specific, and they are used in a very specific way. And there are 3 levels of protective gears. I mean, at least 2 levels. One we call it the dry, one we call it the wet. But depending on the acuity and the severity of the illness, and depending on the patient. So we have very specific criteria about how to put on this gear and how to take it off and how to cover the shoes with those shoe covers. So that's how much I can say. And there is also, like in case there is an Ebola virus, Ebola patient who's been taken care in the ICU, there are specific ways how you sterilize the shoes and take care of this question.
Great. So
we
how are
can add in
patients-
the hospital that we have alcohol available in all patient rooms, in the halls, even outside the place where we put our finger to say we're signing in for the day. So the hospital has lots of alcohol, which is a very effective sanitizer. You could get it as Perel, or so I don't want to, you know, advocate any brand. I don't know any other brand. It's like Kleenex being the only tissue, but any of those things should be effective.
So how are patients transported from an emergency room to the designated hospital, which is Bellevue for now, and what is the method of transportation equipped to accommodate the patient during this transfer? So I guess I'll answer that question because I am the resident paramedic here among all our doctors. So for New York City, we have built very robust protocols, and they have been designated special ambulances throughout the city that the folks who've been trained to put on and take off the special gear and are trained to wear the special gear. So if you call up and you talk about a patient with fever, they're going to ask you a number of questions. And if they have any thought that there may be at risk, then they're going to come and put on their protective gear before they come into the house. The patient is going to travel by himself in the back of the ambulance with the paramedics or the EMTs who are with them. And a family member will be able to ride up in the front, but not in the back with the patient. And that's the same procedure if they're going to go from a hospital, any hospital, to Bellevue. So, question that I can't answer though. Does anyone know if the nurses from Dallas were registered nurses? The rumor is going around that one was a nursing assistant.
I think they were registered nurses, but I don't. The first case, Ms. Pham, was definitely a registered nurse. The second case, the family had requested not to release much information about the second case. So I don't know whether the second case was a nurse assistant. The nurse in Spain was a nurse assistant.
Okay.
And I think regardless of any patient that is working, any provider that's working on a patient, they just need to follow the proper gowning and removal, regardless of whether they're a registered nurse, a patient care associate, a physician assistant. There's those strict protocols that everybody has to follow.
How does the flu shot aid in preventing children in daycare from contracting the enterovirus?
It doesn't. No, the idea behind the flu shot as a requirement in daycare is if children who are frequently a source of influenza to adults are immunized against influenza, they won't get influenza, the influenza won't be spread in the daycare, and they won't give it to the older people. It has nothing to do with enterovirus.
And again, we recommend that everybody, if you can get your flu shot, to get your flu shot. More people will die from the flu than they will Ebola in this country this year. And more people get sick, as is mentioned before, from the flu. So again, why not get the flu shot? We know that's, presenting symptoms are very similar. So if you get your flu shot, something that we can protect against as far as influenza, you can know that you're protected against that in this situation.
Can I add something again? You see, we are very fanatic about the flu shot, but there is one very important reason to keep in mind. As, opposed to the Ebola, you might carry the flu virus and don't have symptoms and transmit it. You can transmit it to an elderly person or to a person who is immunocompromised with chronic illness. And even though it might not, the flu, most of the time, it's an illness for us, but we will transmit it to people who cannot fight it. So it's really a public health important issue to take the flu vaccine. I mean, in the hospital, we monitor it. We want everybody to take it. And, as opposed, to the Ebola virus, the flu infection, you can transmit it for about 24 hours before you have the symptoms and without knowing you have the flu.
We love our patients, but if we don't see you for the flu, we're perfectly happy. So please get your shot.
Great, thank you. Can Ebola be spread through infected workers on a food packaging line or through infected restaurant workers?
I think it goes back to what we've talked about before, and I think it's good to just reiterate it that again, somebody is not contagious until they have symptoms, and you cannot get Ebola unless you're in direct contact of their fluids, or with their fluids rather, and they have Ebola. And so unless that situation happens, the risk is actually pretty low.
Yeah, perhaps you've been watching the NIC where they had Typhoid Mary there who was perfectly asymptomatic. Anybody who has Ebola who is sick enough to transmit it, it was not going to be working on a food service line.
Next question is, do you have any suggestions for the Liberian community living in Staten Island? Liberians are being discriminated against.
Yes.
Okay.
Yeah. So I mentioned earlier, we have been working with not only the Liberian community, but those who are from Sierra Leone and Guinea, and Staten Island, Bronx, Harlem especially as well. And our recommendation is one, information sharing and making sure that we as the health department are reaching out to the leaders that have the voice and that are the influencers, and getting the information back on how best to communicate with our communities. And from that process, we're getting information back as far as, what are the best languages, who are the best leaders, that we can get the information to. We've gotten emails from Liberia themselves, Liberians themselves in Liberia actually, who are letting us know what are the best radio stations to get information through. And so we've been doing those interviews as well. And we have some other, unique opportunities coming up. In regards to stigma, we always, express and communicate, and I think this is important as we go back and step out into with our families and our friends and our loved ones, to let people know that immigration status should not be asked, and whether you can pay or not also should not reflect whether or not you get treated. Because again, one of the worst things that could happen is if somebody and they're from the country and they're not feeling well and they're feeling sick and they're sitting in their place of living and they don't feel comfortable stepping out to seek care, and that would be the worst thing. We don't want to see that happen.
And we've invited the New York City Commission on Human Rights here this evening, so I urge you to stop by their table on the balcony, take the materials, and please share the materials. And if you need a speaker, Derek Slaughter or the lady at the table will be able to schedule. If it's not them, because they're the Brooklyn office, they could tell you who you can go to for the other boroughs.
Mm-hmm.
Thank you. The closest hospital that can give care to the Ebola patient is Bellevue. Why are there no such hospitals in Brooklyn? Other than Bellevue, what other hospitals within New York City care for Ebola patients?
Well, I'll start. Bellevue is the main hospital at this time, and there are 4 other designated hospitals as well. and we are working with them. But that is really a decision, and nobody's sitting here from the New York State Department of Health, because it really is a state regulation as far as who is designated to be a hospital, and I'm sure they have an algorithm that they used in order to designate that, and as to why a Brooklyn hospital is not chosen, really not, I'm not completely clear, but that's a question really for the New York State Department of Health. I don't know if anybody else has, any reflection on that, but that's, what we have heard.
I have a reflection is that our hospital take care of thousands and thousands of patients every day here in Brooklyn. And, we are prepared in case an Ebola patient comes. We will do all the necessary steps to ensure the care. Now, of course, if a patient is proved to be Ebola, we want them to go to the best place where they are even more prepared. So we don't, the resources that have to be put in taking care of an advanced case are quite high. The staff have to go through very strict sort of rules and regulations, and we want to care of our patients. We have old patients who are coming every day. We want to take care of them. We can't stop caring of them while we are, being afraid of the Ebola. So that's my logic answer why the state has made designated hospitals. It is a very, very unlikely event. It's a rare disease. We are doing extraordinary preparation for it, and we will ensure the care, but at the same time, we shouldn't lose sight of the patient who comes to our doors every day.
Absolutely, and again, every hospital will be equipped and prepared that if somebody comes into their door and they are presenting with symptoms and they have gone to an affected country, that hospital and that ER has the ability to identify and to isolate as well. That patient will not be turned away if they come into the door. I think that's very important, and I've been hearing that from community members, feeling that they're going to be turned away.
I think it's also important to realize it's not just the hospitals that are prepared and have done drills and have gotten ready for this, but it's the neighborhood health centers. And so there's many of them around Brooklyn, they're in Queens, they're all over our city, and they are clearly been training to understand what to do if a patient comes in, if they have symptoms, if they have questions. And they will most likely be transferring one of those patients to a formal hospital facility, but they are prepared also.
Has the Department of Health and the Board of Education been working to combat enterovirus?
Yes, I mean, we've been working with our school nurses and other providers in the community to make sure that they are aware. We have a system called the HAN system that when we have policies and guidelines as far as for what providers should be looking for, what they should be recognizing, and how they should be treating, and it's not reportable, but definitely how they should be treating folks that come into their communities.
Okay, there are a few questions left. There are 3 questions left. I don't know that doctors will necessarily be able to answer them. There's a question about a HIPAA violation and them releasing the name in Dallas. How could they release the name? It's against the HIPAA violation. I know that this is a very controversial question. I don't know if you want to.
The HIPAA regulation applies to all patients, and the Department of Health will decide about the public health issue as far as releasing information and exchange of information. But the HIPAA rules applies as far as we are concerned from the hospital perspective and HAC perspective.
Okay. The question of what protocols are there for non-hospital facilities providing health or diagnostic services, but I believe that everyone's covered under the same rules and regulations. And the final question, the U.S. government has declassified documents of study they did in 2000 with the use of nanoparticle silver that successfully dealt with Ebola and anthrax. Why aren't we hearing of this?
I don't know.
Wow, we really stumped on this one. That was good. All right.
If there are nanoparticles, it sounds to me that's some of the vaccine work which has been going on. So it's a vaccine, not a therapy, which would be a way to immunologically present the vaccine. There is somebody who was in the Times who's been doing this in the NIH, and I think it's going into phase 1 trials in the vaccine treatment evaluation units, so it's going on.
So I just wanted to thank all the panelists again for the wonderful job they did. If you have any other questions, please submit it to the Borough President's office. They'll make sure they get it to the right place. I also want to acknowledge and thank Sandra for putting this all together. I know she worked tirelessly, so please let's give her a round of applause. Thank you so much.
Thank you.
Have a good night, everyone.
Have a good night, and thank you on behalf of the Borough President. This is why he holds these forums, because he knows it's very important. Emergency preparedness, Ebola, enterovirus preparedness are all things that we take seriously. So thank you for coming out.
Yes, we did. Yeah.